Welcome to Going Antiviral, the podcast for the IAS-USA, a professional continuing medical education organization focused on HIV and other viral diseases. I'm Dr. Michael Saag, professor of medicine and infectious diseases at the University of Alabama at Birmingham and volunteer member of the IAS-USA Board of Directors. Today, October 3rd, 2025, we are speaking with Donald Abrams, a professor emeritus at UCSF and a specialist in integrative oncology at the UCSF Osher Center for Integrative Health. Dr. Abrams has studied complementary and alternative medicines, including mind-body treatments, botanical therapies, medical use of cannabis, and herbal therapies used in traditional Chinese medicine. He continues to research the health effects of medical cannabis. Dr. Abrams was previously at the forefront of HIV/AIDS research and treatment at San Francisco General Hospital and served as chief of the medical oncology service from 2003 to 2017. Today, Dr. Abrams joins us to discuss the use of medical cannabis. Donald, welcome to the podcast.
Great to be here, Michael. Good to see you again.
It's great to see you. Now, you may not remember this. I first met you when I was a fellow in infectious diseases, and I traveled to San Francisco General as a fellow to give some sort of grand rounds in December of '86. And then I toured Ward 86, which you helped found along with Paul Volberding in the 1983-ish. And I used the notes from my interviews to found the 1917 clinic. So you were really important in my formative years, and your legacy lives on here in Birmingham. So thank you for that.
Well, my pleasure. Yeah, good to know.
Yeah, there's no way you remember the visit because I don't think I would have if I were you. Well, let's dig into medical cannabis. You are the first investigator who I knew personally who was looking into medical cannabis as a therapy back in the 1980s. So maybe tell us a little bit about how you got interested in that back in the early days.
Well, first of all, I did go to college in the 60s just to get that off the table. But at San Francisco General, we've had cannabis in San Francisco, as a lifestyle for many years. And at San Francisco General, we had Mary Rathbun, volunteer of the year for 2 years in a row in our clinic, in the AIDS clinic. She used to take our patients to X-ray, drop off their prescriptions in pharmacy, and also bake them brownies, those special kind of brownies.
Mm-hmm.
And 1992, you might remember the International AIDS Conference was in Amsterdam instead of Boston because we didn't let people with HIV into the United States. And there I was in my hotel room in Amsterdam, glancing at CNN headline news, and Brownie Mary was being arrested for baking marijuana brownies in Sonoma. So when I got home from the conference, Mark Jacobson, one of your colleagues, brought me a letter addressed to the director of research at San Francisco General AIDS program. And Mark brought me the letter saying, maybe you'd be interested in this with your community-based clinical trials organization. The letter was from Rick Doblin, the founder of MAPS, the Multidisciplinary Association for Psychedelic Studies, suggesting that a clinical trial showing the medical benefits of marijuana should be done at Brownie Mary's institution, as if she were our dean. Mm-hmm. So again, I picked up the gauntlet and I said, okay, I can do that. I went to college in the 60s, so I started a 5-year naive fight with the government that ultimately I won.
I want to get into that in a minute. I know that was very difficult because cannabis, if I'm not mistaken, is a Schedule 1 narcotic up there with heroin.
So wait a minute. Don't call it a narcotic. It's a Schedule 1 substance.
Correct.
Misclassified up there with heroin. Schedule 1 is high potential for abuse and no accepted medical use. And it was placed there in 1970 more for political than for medical reasons.
Correct. So maybe let's dig into this now. So you get started in this pathway. You start this battle. Tell us a little bit about what that fight was like.
Well, first of all, Rick Doblin sent that requests. And I said, okay. I sent him the template for a clinical trial to be submitted to the University of California Institutional Review Board, thinking it would keep him busy for a while. Within a week, he sent me back a protocol looking at 3 different strains of inhaled cannabis versus placebo in patients with the AIDS wasting syndrome. And I said, okay, but he was going to get the cannabis from Holland, a Dutch grower. So I submitted this to, I forget, the FDA or somebody to get approval. And they said I needed to seek a domestic source of cannabis because they weren't going to let me import cannabis from Holland, and Holland wasn't going to let me export it until the US said we could import it. And it was a catch-22 situation. So then they said, seek a domestic source. And I said, what does that mean? And they said, apply to NIDA. So NIDA, the National Institute on Drug Abuse, at that time, and still pretty much, is the main source of cannabis for medical clinical trials. So I submitted the protocol to NIDA asking for 5.7 kilograms of their marijuana. And it took a year. And the response was that the protocol was not scientific and that they could not give me the cannabis. And this was from Alan Leshner. He was head of NIDA at the time. And it was Rick Doblin's group protested when he was speaking at a conference in the East Coast. And they met with him, and he said, if Abrams could submit a protocol that's peer reviewed, then we might consider giving him the marijuana. So that meant I needed to submit the grant directly to the NIH for, yeah. So we worked for a long time to make it much more scientific, an inpatient study so that people couldn't give away the marijuana to their friends, et cetera. And it was in 1996, and it didn't get scored. When you submit a grant to the government, half of them get scored, and the ones that are not worthwhile don't get scored at all. And the comments from 3 reviewers were, we don't know why they would choose to study such a toxic substance. And the other reviewer comment that really startled me was, aren't they afraid that this is going to increase tumor necrosis factor and lead to atherosclerosis in these patients with AIDS wasting, who didn't have the luxury of living that long to get atherosclerosis? So finally, somebody said, instead of fighting with Leshner, why don't you go meet with him? So I went to Washington for Clinton's second inauguration. I got invited by a friend, and I met with Alan Leshner. It was very lovely. And I said, I can do this all my life, submit grants to study marijuana, but if I show that it's not useful or harmful, I think people are still going to use it. And if I show that it's safe and beneficial, I don't think it's going to be any more available. And he said, that's where you might be wrong. If you do a study showing that it's safe and beneficial, we might have to rethink the scheduling. This was in 1996, and it's still Schedule 1. And he said, but we are the National Institute on Drug Abuse, not for drug abuse. So we have a congressional mandate that we can only study substances of abuse as substances of abuse. So my request to study it as a therapeutic intervention for AIDS wasting could not be accepted or couldn't be funded by them.
Oh, so you ended up getting the study done.
Because it's my husband, Clint Werner, who wrote the book, Marijuana Gateway to Health, describes it as a Trojan horse study. Because if you remember 1996, that's when protease inhibitors became available, and AIDS wasting sort of a little bit disappeared because we now had effective therapy. However, those protease inhibitors were exquisitely metabolized by the cytochrome P450 system in the liver. And I was having a meeting with some activists who said, because somebody died taking ecstasy with a protease inhibitor. And they said, we'd be concerned about people smoking marijuana on protease inhibitors. So I said, ding, a light bulb went off in my head, and I ran to my pharmacology text and found, yes, cannabis works on those same enzymes in the liver. So I submitted a protocol to see if it was safe for patients on protease inhibitors to inhale marijuana. And that's what got me $1 million and 1,400 of the government's finest cigarettes, which in 1996 was a lot of money.
Yeah, that's great. And so you found that obviously it was safe. Maybe the hardest thing for me for smoked marijuana is understanding how you dose. How do you know how much active THC or other components is getting in?
Yeah, I mean, the mantra is start low and go slow, which is not grammatically correct because it should be slowly. But, I say cannabis has been a medicine for 3,000 years, and I don't think it needs a package insert. I think for the most part, people can figure out how to use cannabis. And in my mind, rescheduling it to Schedule 3, which is what people are talking about doing now, is also sort of ridiculous. I don't think we need a physician interposed between the patient and this very useful, safe botanical.
Yeah. So let's segue over to the medical benefits. You're an oncologist. You've taken care of a lot of HIV patients. Where do you find in your practice that cannabis helps the most?
So let me just say that we and all animals down to sea squirts have a system of cannabinoid receptors in our brain and throughout our body because we make our own endogenous cannabinoids as we make our own endorphins, endogenous opiates. And it's believed that we have the system of cannabinoid receptor and endogenous cannabinoids to help facilitate our response to pain. So the study that I did that really demonstrated the largest effect size was in patients with HIV related peripheral neuropathy, where we did smoke cannabis versus smoke placebo, and it was much more effective in reducing pain. And so I think pain is really the number one. I just reviewed an article that just came out that not only it was in low back pain, the largest study of cannabis preparation. This was a tincture, not smoke, in 800 people with low back pain, placebo controlled. And not only did it relieve pain, but it increased sleep or improved sleep and physical functioning, which a lot of other analgesics don't necessarily do. So, pain, insomnia, for my patients with cannabis, I mean, with cancer, nausea and vomiting, uh, the standard antiemetic that we use on Dancitron is associated with marked constipation.
Mm.
And if you have cancer and feel that you're dying or part of you are dying, you like your bowels to function normally because that makes you feel much more alive. So I have patients forego on Dancitron in favor of cannabis for their nausea, vomiting, pain, sleep, anxiety, depression. So those are six different things, and I could write six different prescriptions for pharmaceuticals, or I could recommend that patients utilize a very safe botanical.
So nowadays, fortunately for the states, they have medical marijuana laws that allow physicians to prescribe. I forget it's somewhere in the 30 something number of states as looked last.
Recommend. Physicians should recommend, cannot prescribe. It's still federally Schedule 1. Yeah.
Got it. And so but there's also, cannabis, for, lack of a better word, recreational purposes approved in a number of states, including California, not so much Alabama. So how when you're practicing in California, how do you approach it? Do you write a recommendation note to the medical, for medical marijuana, or do you recommend it just go to a local store?
Yeah, prior to 2018, when we approved recreational cannabis, I had to write a letter annually for patients to be able to access cannabis from a dispensary. But since 2018, and there is now recreational use of cannabis in California, I don't need to write that letter anymore. So when I see a patient who I think might benefit, I mean, most of my patients already know and already use cannabis. It's not up to me to tell them, but if it is an older person, for example, who's averse to going to a dispensary, a number of years ago, two PharmD graduates from the UCSF School of Pharmacy came to me and said, "What would you think if we opened a dispensary?" And I said, "That would be great." Well, they came back a year later and said it cost $1 million down to open a dispensary So instead, they have sort of a concierge cannabis practice, and I can give my patients either their brochure or their website, and they can consult with them. And for a fee, they find out what the patient's diagnosis is, look at what other medications they're taking, and then they will recommend a tincture and often help facilitate the acquisition of that product.
So if you're just working one on one with a patient who maybe can't afford or doesn't want to go through the concierge, what's your recommendation for how to, you said start slowly and ramp up. What are your recommendations? So let's take an example of someone with back pain but also having trouble sleeping.
Yeah, again, what I do, and Clint, my husband, when I used to sit at home during COVID and do my consultation, said, "Honey, you sound like an idiot telling patients to go to the dispensary and ask the bud tender what works best." Well, I said, "Well, they're on the front line. They must get feedback from people that are using these products. So why not ask them what works best for pain?" So cannabis is cannabis sativa and cannabis indica. They're two different plants. Sativa is supposedly up and mental, whereas indica is down and physical. So if you have trouble sleeping, you don't want sativa at night because it's going to get you jazz. Indica better. Most of the products that are available in dispensaries are hybrid sativa indica products. Then the question is, how do you want to use it? So inhalation gets a bad rap, but when you inhale cannabis, THC, tetrahydrocannabinol, is the most psychoactive component in the plant. And when you inhale delta 9 THC, the peak concentration is reached in 2.5 minutes and it dissipates quite rapidly thereafter. When you take delta 9 THC by mouth as an edible, a capsule, or a gummy, it takes 2.5 hours for that peak concentration. And the delta 9 THC, when it goes through the liver, gets converted into an even more psychoactive 11 hydroxy metabolite.
Mm.
So that's why I see a lot of older women, particularly with cancer, go to the dispensary. They're told only eat a quarter of a cookie. And they do, and nothing happens. So they eat another quarter, and nothing happens. So they eat the whole cookie. And then they've overdosed. And they call me 3 days later saying, "I'm never going to do that again." Maybe having a dysphoric reaction, taking them to the emergency room. Now we have tinctures. A tincture is a liquid. And when you put a liquid into your mouth, you immediately absorb some sublingually under the tongue and you swallow the rest. So it gives you hybrid kinetics between inhalation and oral ingestion. So tinctures are what I recommend mostly nowadays.
And under the tongue, when it does get absorbed sublingually, it evades the first pass effect of the liver.
Exactly. But then you swallow the rest.
Oh, and then it goes through the liver. Okay, that's interesting. So, what about CBD versus THC delta 9? Are there times when you'll just recommend that without looking for the THC effect?
To be honest, I never recommend CBD. CBD has become a multi-billion-dollar business in the absence of any evidence that it does anything. And last year, the Journal of Pain had a huge article: CBD, ineffective, expensive, and harmful. And they reviewed 16 placebo controlled studies of CBD in pain, and only one of those 16 had any benefit. And it was a topical CBD for arthritis. They did a large placebo controlled study of a CBD oil up to 300 or 400 milligrams
Mm.
in patients with advanced cancer, palliative care patients. No better than placebo in reducing symptoms, improving quality of life, or decreasing depression. I think CBD has catapulted to the top of the most favored cannabinoid because it's not psychoactive. Well, the one study I think that demonstrated best that CBD may have some activity was in anxiety. So if it works there, it's psychoactive. For me, the dosing of CBD, and that study used 600 milligrams of CBD. When you
Yes.
go to the Whole Foods at the checkout station, I think the CBD there is 10 milligram. So CBD actually changes the shape of the cannabinoid receptor so it can't complex with THC or with our own endogenous cannabinoids. So I am not a fan of CBD.
How long does that transformation last? Of
I'm
the
not,
of the
yeah,
receptor, yeah,
called a negative allosteric modulator, but
got it.
uh,
But I mean, that I assume that's reversible once,
yeah, yeah, yeah,
yeah,
yeah,
yeah, okay. Well, it's
yeah.
interesting because a lot of the dispensaries that I've sent
Oh, yeah.
patients to, yeah, that's like it's one of the things you can get in Alabama, but, if at 10 milligrams, it sounds homeopathic.
Well, and we did it. In the spirit of transparency, I shared a study from BraveNet, our practice-based research network in integrative medicine. We enrolled 400 patients in San Francisco, San Diego, and Chicago who were obtaining CBD, predominant CBD enriched products at dispensaries and being seen at 3 clinics. And 400 people did claim that it was useful for pain, sleep, and anxiety. But that gets me to the study where they did CBD versus placebo, and they did an experimental pain model. And they told the patients it was a 2 by 2 factorial that they were getting either CBD or placebo. So the patients getting placebo, who were told it was CBD, had more relief of their experimental pain than the patients getting the CBD.
Hmm.
So there is this expectancy, and that if that's the placebo effect and it works, then so be it. But I don't think it should be a multi-billion-dollar industry.
And I'm also thinking about a lot of the dispensaries around the country where you say go to the budsman or whatever the guy's name is
But
who sells it. Yeah, but they do talk about these combo
yeah,
gummies and whatnot at CBD and THC. And in listening to what you're saying, that's probably a really bad idea because
well,
you're changing the receptor.
yeah, changing the receptor and you're changing the metabolism of the THC. I think that's probably why CBD is in the plant to begin with, to sort of alter the metabolism. I think if people can't tolerate the high of THC, then CBD modulates it. And for people that are not cannabis experienced, maybe a THC CBD product. But there are 150 other cannabinoids. When I went to college in the 60s, if we smoked old dope, as we called it, we would get sleepy because THC degrades into cannabinol or CBN. So CBN is now very popular for sleep. I'm not a fan of isolating the individual cannabinoids or terpenoids or flavonoids. I said nature does it best. The plant is the best medicine. There is one cannabinoid that I think might be interesting, tetrahydrocannabivirine, because it decreases appetite apparently for food, for alcohol, and opiates. So it might be something worth, developing as an isolated cannabinoid therapeutic.
It sounds like a GLP-1 agonist.
Yeah, maybe.
Maybe that's how it works. Um, well, as I listen, I'm intrigued by all this, and I'm looking also at our time is flying by. Um,
Well,
yeah, and this is just awesome. Can you tell me what do you think the future is? I know all of us would like to see the schedule get changed after all these years, even with uh, recreational marijuana in a number of states not demonstrating a whole lot of detrimental effect. It's still a Schedule One. Uh,
yeah.
what are the types of things, in addition to changing that, would you like to see happen in the world of medical use of cannabis?
Again, do we need to have physicians interpose between the patient and the botanical? I don't know. I mean, we do. It's so difficult to collect data. This large study in low back pain used a single uh, plant extract product. So the same thing was used in 840 people over a year. That's pretty impressive. Other studies, you use this product for 6 weeks, 4 weeks, 7 days, so do we need more studies? I mean, one of the biggest things that I see in cancer, patients believe that cannabis might cure cancer. Not so
Mm.
much anymore, but 5 years ago, I had many patients forego active cancer treatment drugs in the hopes that high doses of THC or plant extract will cure their cancer. And it doesn't, but does it do anything? I don't know, maybe. So, as an oncologist or former oncologist, I would like to see a little bit more evidence or data about cannabis and cancer. But otherwise, I'm embarrassed to say that I'm at an institution where all they come up with now that I've stopped doing my research are the negative effects of cannabis on the cardiovascular system. Now, a recent article published that it increases the risk of asthma and COPD. It doesn't do that. I'd like to see cannabis be available for anybody who would like to use it. You said in states where it's legalized, we see decreased opiate overdoses and deaths, and I think decreased negative effects of alcohol.
Mm. But I think, obviously we don't want somebody who's ingested to be driving necessarily and that type of thing. There have been some accidents that have happened, but that's just common sense at that point.
Well, yeah, okay,
Yeah.
I'll leave that.
But one of the other things, demyth this for me. There are several reports that I've read that say that, especially in adolescents or old young adults, that use of cannabis can uncover or expose schizophrenia. Is that something that's true? And if so, what's the incidence?
Yeah, no, again, I'm not a psychiatrist, but I was on the committee from the National Academy of Science, Engineering, and Medicine that reviewed 10,000 papers and published the health effects of cannabis and cannabinoids in January of 17. And I do believe we had conflicting statements in the book. One, that maybe cannabis use in young adults can increase schizophrenia, and the other one was that cannabis use in schizophrenia uh, decreases the thought disorder.
Mm.
So I've heard in the past that what happens is young adults who are going to be diagnosed with schizophrenia find that cannabis is very useful for their thinking. And so they use cannabis and then they're diagnosed with schizophrenia. So was it cause or effect? And I think that's an issue that we still don't really know.
Right. Well, our time has flown by. I am very grateful for your time today, but also explaining a lot of the nuances of where cannabis can be used, some of the pitfalls, especially with CBD. I was not aware of that story. It's really important, I think, for folks to know about that, and where the future might be. I want to just compliment you on the work, your life's work, not only in the treatment of oncology, but the treatment of HIV. Your team, all of you at San Francisco General, led the way in developing outpatient approaches to care that many of us, including me, emulated and got programs started that were not only focused on the medical aspects of HIV, but the comprehensive approach to care that you guys really set as a standard, and I think a lot of us have followed. So thank you for that. Thank you for being with us today. It's been great, and I hope to see you in person sometime soon.
And that'll be fun.
Thank you. Thank you for listening to this episode of Going Antiviral. Catch up on earlier episodes wherever you listen to podcasts, and check out the video versions of this episode and others on the IAS-USA YouTube channel. You can find these links in the show notes, or simply go to YouTube and search for IAS-USA, and there they are. Be sure to subscribe, rate, and review Going Antiviral on Apple Podcasts. This podcast is for informational and educational purposes only and is not intended to serve as medical advice. Opinions expressed on this podcast do not necessarily reflect the opinions of the IAS-USA and its affiliates. And the viewpoints of the individuals on this podcast do not necessarily represent the viewpoints of their institutions. If you have a question you'd like answered on the show, you can send it to podcast@iasusa.org to be answered in a future episode. Thanks for listening.